Hey, are you struggling with third molar surgery in your practice? Do you want to make third molar surgery more predictable, boost your income, and improve your outcomes? Well, congratulations, you're in the right webinar. For the next 45 minutes, I'm going to give you the exact tips and tricks for you to smile through surgery. So let's jump on in. Let's roll. Surgery tips, tricks, and best practices. All right, let's do it. So here's my IG. Here's YouTube. I put a lot of information up on YouTube because I see a lot of patients that are being harmed by surgeons and general dentists doing surgery. So my focus is to really give the GP and the patient information to help each other. So if you're a buzzard, like we used to say at Meharry, please be aware because I have definitely given patients insight on how to get you if you're not acting right. But if you do what's best and you take care of the patient, you're all about service, everything's going to work out. So there's some information on here. There's my contact office, email, and also the website if you want to learn a little bit more. Let's do it. All right. So let's jump into this. So this is a research paper that I found, and this is from a public health doctor by Dr. Friedman. And this was done in 2007. And I want to let you highlight this for you. It said 10 million third molars, wisdom teeth, are extracted from approximately 5 million people in the United States each year at an annual cost of 3 billion. That's billion with a B, all right? 3 billion. Now I want you to see that. That's 2007. If you could do some math, 25 minus 2000 minus 7, you kind of get an idea how much it could actually triple, quadruple over that time frame. So that was in 2007, 3 billion. So if you do some simple math, really simple, 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 I'm a really simple person. If you do some simple math, 3 million divided by 10 million people, 3 billion divided by 10 million people is $300 a person. Now, if you look, according to ADA, it says that as of 2022, there were over 202,000 dentists active in the United States. And 60% of those, and so yeah, so just to give you my idea, is over 200,000, and that's 2022. If you look at here in Texas, where I am, there's over 15,872 clinicians, and that was in 2020. All right, just doing some math here. Now, before we get started, I just want to share with you who I am, but I want to pique y'all's interest about how much money y'all leaving on the table if you're doing a lot of referrals. I went to Meharry. All right. I did my VA. I did post grad at GPR at the University of Pennsylvania, which is a VA hospital. I did an IV sedation certificate at Augusta University, and then I also went ahead and started doing concierge dental surgery, which is basically I travel different offices doing thirds, implants, and sedation, and been doing that for a little over 12 years now. I've completed well over 12,000 cases. I'm also attending at the UT Health School of Dentistry here at the GPR AGD program. And we also was able to create the JW method, right? And the JW method is all about training GPs how to do third molar surgery with efficiency and with little to no experience in less than 4 to 6 weeks. How do I know? Because, and I'll share it with you in just a second. I'm a speaker and a lecturer and also an author of this book right behind me called How to Get Any Patient Numb, Third Molar Edition. So I don't care where you are in your whole grand scheme of things. I promise you, I promise you, I promise you, the information I'm gonna give you today, you're gonna be able to use tomorrow, Tuesday morning. Here are some of the places I've been able to lecture at. Chicago Midwinter, that was just past a couple weeks ago. UT, ACDE, Star of the South, the NDA, and the Yankee Steady Club. So I just want to let you know the information I'm giving you right now is just information that I've been called to different major societies and major conferences. Hey, Dr. Williams, we want to hear what you have to say, and I'm giving you all this information here today. So everybody likes to talk about how good they are at day present. And I want to let you guys know that this was me at Meharry. All right. So all you Meharians out there, these are scrubs that we used to have. And the scrubs that we used to have were these khakis. All right. So this is me and Dr. Smith. This is when we were sitting out in front of Michael Jackson's house. Um, and we went to Chicago. And so we went to this area. And so we decided to take a picture out in front of his house. But the reason I wanted to share with you this is that when I was
coming up in dental school, I knew I wanted to separate myself from all my other classmates because I was in the middle of the pack. And back when I was at Oakwood University, I had a 2.46 GPA, right? So I wasn't the smartest person at first, but I always knew I was going to be great. I was just a slow developer. And the way in which I decided to speed everything up for myself was to get around mentors. And so I did just that. So before I got proficient with doing third molar surgery, man, I was being able to have a little bit of success, but then sometimes I didn't. And so this is a tooth that actually got pushed in the pterygomaxillary space or the infratemporal fossa, depending upon how you want to categorize that. And that was me. That's something I did. Now, this wasn't not when I was at Meharry because they wouldn't let us do this, but this is after I started practicing about a couple years out. And I knew I wanted to do surgery. This is after I got my IV sedation certificate, after I went through residency, and I was still a buzzard, right? For all you Meharians, y'all know what I'm talking about, but I was still a buzzard. But what happened was this over time, I got with the right people. And this is that case that I was telling you guys about. This tooth got stuck in the infratemporal fossa. Typically, these cases should go straight to the OR without any question. But after finding the smartest people in the room and submitting to them, God has allowed me to be around some very intelligent men and women. And every time I'm in a room with individuals who are smarter than me, I humble myself and I listen, I take notes. And after me being able to learn thermolar surgery, this is actually one of my mentors. Um, when I told him about this case, he was like, "Hey, Jared, I know you. I know that you care about patients. I know you studied, and I know you put in a lot of hard work. So go ahead and get it." And I was like, now, when this case happened to me, I almost, I almost crapped on myself. Like I had to test and see how strong my sphincter was, but it wasn't until he believed in me to say, "Hey, I want you to take care of this because you can." I decided to go back in the drawing board, take care of business, and I was able to get this tooth out. And so here it is right here, right? Didn't have to send it to oral surgeon or anything like that. Because imagine being a black male doing oral surgery, taking advantage of a $3 billion business, and then sending this down to our friendly local oral surgeon. It wouldn't have ended well. But after putting in the work, humbling myself with these mentors, and also making sure I'm faithful over the small things, God put me in a position to share with you all this information. When I say I want you guys to be successful, I'm not just saying it so I could make y'all feel better about yourselves. I believe that there's greatness inside of you all, and I want you to see it so that you could use your gifts to change this world. So let's jump into it. Today, we're going to have six items: building rapport, local anesthesia, flap design, root morphology, and sectioning and post-ops. And if you stay to the end, I got a special treat for you. Like we said, we're going to be giving a giveaways. So if you stay to the end, we got something for you. All right. So building rapport. Building rapport is basically like you're just getting a friend. That's all that it is. Building rapport. And so what I want to do is take you in the rubric of tips, tricks, best practices, and what happens if you fail, right? A failure. Now, this is something that Dr. Monica Wheeler said we got to talk about failures because everybody likes to just show the good stuff, but I also want to show you the bad of if when you don't follow these things. All right. So here's an easy case. How do I know it's an easy case? Because it's far away from the nerve. Here's your nerve, and we're far away. There's no bone going over the occlusal surfaces of these lower teeth. It's not, there's a good path of draw. We're far away from the sinus. There's no destruction of any teeth nearby, and there's no crown. So that kind of gives you know that's pretty much of an easy case. If you're a beginner, you should be able to take do this case in about 30, 45 minutes, even with anesthesia. All right. If you're intermediate, probably knock this out in about 30 minutes. If you're advanced, you probably do this in about 5 minutes, if that. Maybe 7 minutes, maybe 10 minutes with local. All right. So in order to build rapport, here's a tip. All right. So if you're taking notes, let's start taking notes. Tip number one: take off your mask. Right. When a patient comes in, they're extremely fearful, and when you take off your mask and you take off your loops and you take off the light and you take off all your regalia when doing surgery, what that does is it allows the patient to just be at peace. When you don't do this, it makes the patient extremely fearful, and you're screwed before you get started. All right. So just want to throw that out there. The next thing, a trick. Ask questions to break the anxiety pathway. There's this anxiety pathway that I've coined to where patients are stuck in when they come into your driveway and pull into the parking spot. They already have had the anxiety. As a matter of fact, the anxiety started the night before. And so when you ask questions about the patient, it takes the stress off the patient, and it allows them to just be at peace for just those couple of moments. And if you do this exactly, I'm telling you, your patients, when it comes to third molar surgery, are going to fall asleep in your lap or in your chair without you give them any type of nitrous, oral sedation, IV sedation, or anything along those lines. I call it verbal anesthesia. And you want to ask questions that basically show them that you care. So if they have a nice shirt on, if they have a nice earring, if they have a nice tattoo, if you ask them questions like, where'd you go to high school, like age specific questions, it just gives them that 2 to 3 seconds to break that anxiety pathway so that you could go ahead and get the information you need without them being so tensed and uptight.
Like 20 minutes was it? He even counted. For him, we were like an eternity. It was like, what? We're done? What, the 4 wisdom teeth out in like, what, 20 minutes? That's amazing if you ask me.
Thank you.
Judging from my own experience, which was really bad.
What was your experience?
I think like 4 or 5 minutes, 30 minutes, only one.
Really?
And it was painful. And he barely felt any pain. He's like, I'm good. Like, we're the 4 out. Like, you are amazing. If I ever get like my upper wisdom teeth, I'm coming with you.
All right, so that's a patient who, as you can see, I was working on her brother, and she comes in and she had her anxiety pathway already going because of a past experience that she had with one of her doctors. And so, as you can see, by building rapport and allowing the patient in the chair to have a wonderful experience, it'll waft off to other family members and friends and colleagues. And now you just have a walking referral everywhere you go. So, that's how you build that relationship, because if you have a good patient relationship, doctor patient relationship, you're going to make more money. You're going to no won't have to advertise. You'll do so many more surgeries, and you'll do them with ease because everybody is at peace. The anxiety pathway is broken, and you can do a lot of good work and serve your patients at a high level. A failure. If you don't do this, your patients will be moving and anxious the whole entire time. And one thing I found after practicing for over 13 years is this: no amount of drug is going to break that unless you take them GA. And sometimes even going GA, some patients will still fight you. So I just want to let you guys know, follow this building rapport because it's super important. And if somebody talks about it as the first thing, that's something that I want you to really focus in on, because that is key. I don't care how, if you could lay a flap, if you get the patient numb, if you can't build rapport with your patients, when something goes wrong, not if, but when something goes wrong, you're down, you're going down fast. So, local anesthesia, tips, tricks, best practices. Let's jump into it. So, here's another, once again, this is the same case. So, what I want for you to do is this: throw out your 30 gauge needles. You want to use your 27 longs. The short needles aren't going to do anything for you in surgery. It's not going to allow the patient not to feel the needle less. All right. So just throw that out of your mind, because I'm going to give you a technique that another Maharian taught me. And I got to give her credit, Dr. Angela Brown, right? She's the one who helped me with it. And so I want to give her credit, another Maharian. And the tip: throw out your short needles. All it's going to do is cost you money, and you're not going to help you do anything more. All right. So I'm saving you money and saving you focus. All right. So most people, when you do local anesthesia, you're taught accuracy. All right. You get your weapon of choice, your needle, and you start shooting, shooting, shooting. Now, accuracy is hitting the actual target, but not hitting the bullseye. And a lot of doctors will go ahead and get their anesthetic and start shooting, 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 shooting. And that's not ideal, right? And so what I challenge doctors to do is don't use the IN, but use the Gal Gates on everybody: kids, adults, people who have HIV, people who are males, females, young, old, diabetes. blood pressure 200 over 100. It doesn't matter where they are, what's going on, what their medical history is, do the same injection every single time. It's not going to be more challenging or less challenging on the patient. All right. As a matter of fact, you have less likelihood of having aspiration of blood in the actual carpule than if you did an IN. Precision is essentially different because you're hitting the same spot, but you're not hitting the actual target, right? So if you think of that you're shooting, you're just hitting a certain spot, but not hitting the target. And that sucks because if you're trying to take out a lower third molar and you're not hitting, and you're not taking what I like to say, going to the breaker box and turning the electricity all the way off, or just going to the switch, you're going to end up getting yourself fried. And a lot of patients are like, oh, they start jumping and doing all these and start moving and shaking, and that's not going to help you. So we're not wanting to get precision or accuracy. All right. One thing I teach doctors in this book right behind me is how to do it the JW method. So what I teach doctors is this: always do the gal gates, and I want you to use a pivocaine plain. What that's going to do, it's going to act like a shotgun. And as you can see right here, it shows that that shotgun is going to get closer to the actual target or the bullseye. And when you follow it up with lidocaine, which has epinephrine in it, which closes the blood vessels, what it does is locks that medication in. So when you hit it with a shotgun, it wafts out like pellets. I don't know if y'all ever shot guns, but in Texas is all we do. You shoot the shotgun, it goes into the area, and then you follow it up with a sniper, which is lidocaine. And what that will end up doing is allow your patient to get more profoundly numb so much more quickly. And as you can see right here, you're going to end up hitting majority of the target and some other areas and actually get the job done. It's not uncommon for patients to be like, man, my whole head and ears numb. I was like, good, because then they won't bother me when I'm getting to work, and they won't bother you as well. So it's not about accuracy. It's not about precision. It's about the JW method. And when you use that shotgun approach with your pivocaine and you use your sniper, which is going to be your lidocaine, you're going to have profound anesthesia every single time. All right. Best practice. I'm going to share with y'all what I do in surgery. All right. So part of this video you're not going to see in the what is it? In the landmarks, but I want to let you know this is how I'm giving anesthesia right here. I shake, 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 and as I'm aspirating, I'm injecting as well. And patients are able to endure at least 10 shots in about 60 seconds because I want to get in and out. So there you go, that lidocaine, and I'm pushing and I'm aspirating. And as you can see, there's no blood coming out of that carpule at all, right? And so this is exactly what I'm doing on every patient. I don't care if they're male, female, young, old, 30 medications, no teeth, with teeth, whatever the case may be. I'm going to shake and I'm going to do a little aspiration and inject. If you're not doing this on your patients, you are doing a significant disservice, because what's happening is this: I'm distracting the patient so they're not going to feel that little pinch on initial contact. And most patients, they're like, what'd you just do? I was like, oh, nothing. They're like, why is my face getting numb? I say, I got medication in my gloves. And you can't tell you how many patients go for that. And I'm not just talking about pediatric patients, Dr. Cherry. I'm talking about all patients, all those who treat doctors. Who treat adults, because I don't treat anybody below the age of 12, especially with sedation. So I just want to share with that. So the big takeaway I want to show you guys here is shake the cheek, aspirate, inject, and always, always, always use the gal gates with a pivocaine and a carbocaine. Pivocaine or carbocaine, which is basically the same, and then followed up with a lido. Failure. If you do not shake the cheek, if you do not use mepivacaine and you just start firing, you would have given at least 6 carpules in one spot, which is going to be the either IAN, which most doctors do, and your patients will sit there just like this. And that type of energy is not good. It's not good for you, not good for your dental assistant. It's not good for your schedule, because the patient's going to be sitting there like, oh my gosh, this person's a freaking idiot. This doctor's know what they're doing. Then your assistant's going to be looking like, doc, you all right? You can be like sweating all down your back. You can be looking like, man, God, why did I even do this? I shouldn't have done this. Should have referred the patient out. How do I know y'all feel that way? Because I used to feel the same exact way until I started doing this same approach. After I started doing the pivocaine and lidocaine with the gout gates, patients started to get profoundly numb, and I was like, "Oh shoot, good, we're good, we're good." And that's exactly how it kept on flowing. All right, flap design. Everybody talks about flap design. How do I get better flaps? How do I get better flaps? Well, I am a simple person, so let's jump into it. So when we look at this case, this is going to be an intermediate case. Why is it going to be intermediate cases? Because once again, we always want to look at the nerve and just trace it out. So this nerve is basically on the root, but I don't think there's no communication here. So we're not on the nerve. On this one, you could see it kind of doing a little Michael Jackson touch, a little this the root touching here. And so when I see a tooth like this is an immediate case already, because if you try to take this tooth out and quickly, you could probably end up damaging the IN. And if you damage an IN, then congratulations, you just severed the nerve or compressed the nerve or ripped the nerve or done something iatrogenic, which means you caused the trauma to that patient and now you got to deal with it. And so in order to get away from that is this, you just have to identify it. If you identify the nerve first and then work your way up, then you're in good spot. But if you just look at the crown and be like, okay, I know what I'm doing, you're screwed. Because most doctors would probably code this tooth a surgical extraction, when actually it's not a surgical extraction at all. Surgical extraction typically runs um, roughly from 290 to 350, depending upon where you are. If it's Medicaid, maybe $100 here in Texas. If you were to do, if the code that I would tell you what the code actually is, the code is actually 7241, which is a complete bony with complications. And this code, this tooth would probably run about 695 to 780 for just one tooth, just because this is right here. And it presents just like a surgical extraction like this one right here, but it changes because it's sitting close to that nerve. All right. And so by just being able to see that little bit of information, that's going to save you from ever damaging the nerve. While all your classmates are getting all happy, taking out teeth, like, man, I can't sleep because my patient called me and having numb lip and jaw. That's the reason why. All right. And so don't ever feel as if it's uncommon, because I'm part of a secret society and I get a lot of stuff come my way. And I see a lot of non-general dentists having these types of cases. So I just want to let you guys know, if you follow this information I'm giving you, you will be successful by default, because I'm only giving you guys the principles. These upper teeth are pretty straightforward. They're conical roots here, not in the sinus, and there's no restorations here. So these teeth should just roll on out. If we were to classify this, if you were a beginner, I would say don't even touch it. If you were intermediate, probably take you about maybe an hour and 15 minutes. If you're advanced, you probably do this in about maybe 45 minutes. So just kind of give you a heads up there. All right, so how are we going to do this flap? So back in kindergarten, you were taught so many shapes: a circle, square, triangle, trapezoid. So I like to just go all the way back to kindergarten, keep it simple. When I was at Oakwood, I had a 246 GPA, and I just like to keep things real simple. So anytime you're going to lay a flap, always lay a flap in a triangular fashion. And by doing that, the principle is this: as long as your base is wider than your apex, you're good 99.9% of the time. If you have your base wider than your apex, you're good. So here's your base and here's your apex, or the point. And there you have it. You could do it with ortho, you could do it without any ortho, you could do it anywhere. You're good, because it's just a principle and you can follow principles anywhere. I've been on different continents doing surgeries, and everybody bleeds, and tissues are roughly all about the same, relatively. All right. So one thing I want you to do, here's a trick on laying your flaps. Now, what they teach you in contemporary oral maxillofacial surgery, I got my book here somewhere, but it talks about wanting to do a insulcular incision all the way to the second premolar. That's a terrible way to do it. As a GP, you are trained to work in millimeters at a time. So when you flap, what I want you to do is the same exact thing. And most oral surgeons don't do crowns, but most GPs are on here or most doctors who do crowns are on here. And so what I challenge you to do is don't involve the flap on that 12-year molar, right? And you can see that little piece of tissue right there that's still involved on that 12-year molar. So when you're going to take out that tooth, that's all the bone reduction that you would need, and that's what your flap should always look like. And you could see there, right here, there's your base and there's your apex. And when it's reflected, you could see that the tissues have not been compromised whatsoever. You could see that right there. And there's your flap. All your flaps should look the exact same, just like that one. No different. All right. So, best practice when you're doing the flap, you should always stay buckled to the central or the buccal cusp of the 12-year molar, right? If you get on the central fossa and you start going towards a lingual, you are going to have a surprise and a little plaque that says, "Congratulations, you just severed the lingual nerve," right? And we don't want those types of certificates. We don't want those types of plaques. Those don't help us. All right. So, what I want for you to do is this: anytime you lay a flap, it needs to be buckled to the buccal cusp of the 12-year molar. So stay buckled to the 12-year molar. Think of that the green area. Yellow is going to be the central groove. And red, kind of like red light, green light, where you don't want to go, or that's where you want to stop. Anything lingual to the central fossa. All right. So I'll say it one more time. The lingual fossa, the central fossa, lingual to that, red light. The central fossa, buccal to that, yellow light. Where everybody should be operating on 98% of all their cases should be buckled to the buccal cusp of the 12-year molar. All right. If you fail to listen to me, if you fail to listen to me, you will cut the lingual nerve. I remember I was working with a doc and he was telling me how he was doing a consult and this 15-year-old girl comes in and she's like, "Hey, I can't feel my tongue." And the mom's upset and the doc's like, "What's going on?" So he does some evaluation. Patient opens up their mouth and you could see some of the scar tissue that the previous doctor surgical site. And you could tell that the doctor went lingual to the central groove of the second molar, or the central groove of all those molar teeth, and cut the flap on lingual to it. And what they did is they pulled the tissue from here towards a facial and encapsulated this lingual nerve that you could see in yellow. And by doing that, this doctor got a certificate and a plaque that said, "Congratulations, you're getting sued. Congratulations, you are also going to pay through the wazoo with a malpractice lawsuit." And then also, um, extra prize is that you also lose confidence and you have a numb patient. So these aren't prizes I want you guys to play with. So that's why I say just stay buckled to. And there's research that shows that the lingual nerve could go different areas based upon where you are on that lingual side of the ramus. So I just say just leave it alone. That's why I say it's in the red area. If you stay buckled to, it's impossible for you to ever disrupt the lingual nerve unless you push the tooth towards the lingual, which I don't think you should be doing anyway. But I just want to let you know, just keep that flap buckled to the buccal cusp of that 12-year molar. And every time you can go to sleep at night, you go watch movies with your friends and family and spouse and just enjoy the day without getting a phone call saying, "Hey, doc, your patient's in the hospital." Or, "Hey, doc, your patient, the oral surgeon wants to talk to you." It doesn't feel good. Doesn't feel good. All right. So here's research saying that the lingual nerve is this little white dot right here. What they did here is they put a little silver rod into the lingual nerve to map out the distance of the CEJ to the actual lingual nerve. And so as you can see it there, as you can see there, what it's doing is it's just showing you the distance. But I don't trust it. I don't trust it at all. The reason why I don't trust it at all is because I don't want the lingual nerve to be up here. and then I try to do my flap. So I just stay far away. I don't even have to mess with it. So that's why I say to you, stay buccal to the buccal cusp of the 12-year molar.
Hey guys, I want to let you know the information I'm giving you in this webinar. I know it seems very, very, very specific and detailed, but I want to let you know this is the same exact information I used at the Chicago Midwinter, where individuals were giving me a standing ovation from this exact information. But I want to let you know if you stay to the very, very end, I have a very special offer just for you. And what it's going to do is allow you to deepen your knowledge of third molar surgery so you and your patients could smile at surgery. Let's jump back into the webinar.
All right, sectioning. Everybody's trying to figure out sectioning. So I'm going to share with there's 3 cuts that you need to have for all your cuts. You don't have to use any other cuts, but 3. I'm going to share with you one today, but 3 cuts. All the cuts that you need are just 3, but I'm going to share with you one today. Maybe 2. I can't remember. We'll see. All right, so here's an advanced case. How do we know it's an advanced case? Is because I'm gonna track the nerve. And as you can see, I'm gonna do the same exact thing every single time. I'm a simple person. I just like results. I don't need the flash. I just want the results. Look at the nerve, then I look at the roots and I look at the crown. So as we can see here, we have the nerve going intimately connected to these roots. So automatically, I know it's 7241. I don't even need to look at the crown. 7241, complete bony complications. Same thing here. I know it's also going to be advanced cases because this mesial cusp is locked into the distal part of this 12-year molar, just like it is in here, right? For advanced doctors, it's going to be pretty straightforward, but for those that are intermediate, it's going to be a little challenging just to kind of wrap your head around it. But I don't care if you're a beginner, intermediate, advanced. I train all doctors the same exact way, and that's why doctors are like having so much results, and I'll show you some insight from that in a second. So as you can see here, this is an advanced case. This one up here is an advanced case as well because this tooth is similar to one I was telling you all about before, that it could like jump in the pterygomaxillary space and just float. Essentially, it'd be between the ramus and the maxilla. And that's a crazy place to be because it's just suspended and there's no bony compartment that you could press upon, right? So when that happens, it's like one of these things where it's like, okay, crap, how am I going to get it? And you just have to have surgical skills to get there. But looking at this case, this is an advanced case, and this was it'll say beginner. So if you see here, I would say beginners don't even touch it because you're working with the nerve. If you're intermediate, I would say it probably take you about maybe a good hour and 30 minutes. Um, if you're advanced, I'd say maybe an hour and 15. If you wanted to take on a case like this and you were like, man, I really want to do something like this, I would say you can do it with further training and further like guidance. I don't say just get this information, run with it. You can, but I'm saying as a disclaimer, as an educator for many years now, I say get a little more extra training because I don't want you to get hit with a board complaint. I don't want you to lose your confidence. And those are like 2 big things that I don't want you to fall for. So with that being stated, if you ever said, hey, I want to do this as an intermediate or advanced, I would just say on the lowers, just do a cornectomy. And that's essentially where you just take the crown off and bury it about 4 millimeters below the CEJ and you're good to go. A tooth like this, like I said, is going to run you from anywhere from like 600 to $850, depending upon where you are. Um, Same thing with this one. This is gonna be like a complete bony. It's probably run you about a good $500 or $600 maybe. And this one, maybe a surgical, probably be about another $400. So if you did 8, that's 16 plus another 5, that's 21. So maybe about $2,400 on just this case without any oral sedation. So as you could see, like these oral surgeons that are these specialists that are saying, hey, send me your patient, I'll take care of them. You could see like this case right here is just $2,500 and this is without sedation. In a case like this for them would probably take them about maybe 45 minutes, myself, maybe the same amount of time with sedation. And so this is what you're leaving on the table, but I wouldn't say jump on a case like this when you're first getting started. But it's definitely can be done for even doctors who have never laid a flat before if you follow instructions in a more intimate situation. So here's a tip. Get a surgical 557 burr. This is the only burr that you need. I found that the cheaper the burrs or the non-brain burrs that you have, like a Henry Schein, I'm not being sponsored by anybody, so I just want to throw this out there. Like a Henry Schein or like a Patterson or um, I can't remember some other ones, but like some regular, like a Benco, those burrs tend to be so much better than like a SS White or a Meisinger. They just seem to separate at the bevel at the beveled area or the yeah, this bevel. So just that's something to just be aware of for that. So 557 surgical length burr, not a 557 where you're cutting crowns and doing removing decay, but a 557 surgical length burr. All right, so here's one of those sections I was telling you about, and this is going to help you with all your multi-rooted teeth. Anytime you're going to section, you have to go 1 millimeter past the furcation. Go 3/4 of the way past the central groove, which is this right here, and then stop. Once you get there, go 1 millimeter past the furcation. Now, even if I were to be training the most novice person on here how to take out this tooth in maybe one case, you'd get it like this. And the reason why is this is I would tell you to take this cut and take it all the way down into the furcation right there. And by doing that, you're going to end up being able to take this tooth out one piece at a time. This is a regular case for me. It's not a big deal because I've just done so many of them. But once you start understanding how to section teeth, your case selection and your cases are going to start going so much faster. You're going to be able to treat way more people. So once again, the furcation cut, you want to go 1 millimeter past the furcation, and then buccal lingual, you want to go 3/4 of the way past the central fossa. And then once you separate it, you should create two premolars. All right. So like we talked about before, if you were to look at to doing a cornectomy, like for this case right here, what I would just tell you to do is take the crown off and remove the tooth 4 millimeters below the CEJ or I'm sorry, the alveolar crest. Sorry, alveolar crest. So here's pre-op. Here's 10 days post-op. Here's 1 year post. Here's a 7-year follow-up. I used to think that you're a buzzard leaving roots behind on a tooth, on any tooth. That's false. Research shows that if you have nerve involvement, I'd rather you have now I'm telling you, I'd rather you do an ugly cornectomy and there's nerve involvement than a pretty post-op pano where the roots are completely gone, but the patient has a numb jaw. So failure to do so. Now, this is actually one of my patients right here. This is early on in my career, maybe at 2 or 3 years out. I knew that she was going to have nerve involvement, but this is before I started doing cornectomies. And you could see I did a nerve map and I tested her to follow through with her. And I let her know, hey, you're going to have this before we get started. She's like, I don't care, just get it done. Looking back at it, I wish I would have just done a cornectomy and, saved my ego a little bit. But at the time I was ignorant. But my ignorance and my pain and the money that I put into my education, I want to make sure y'all do it so y'all could have some wonderful experiences. And if you squint real good, here's a IN right here. So you could literally see these in action when you're doing surgery. All right. So get results. All right. So we went over tips, we went over tricks, we went over best practices and failures. Now, so I know some people are on here like, you know what, Dr. Williams, that's great. Is that going to work for me? Well, I don't know. I think it will. Why? Because I've done it so many times, and I realize like a lot of GPs, it's not your fault that you're feeling the way that you are. It's because your education and training. How do I know? Because I've did just about everybody's education outside of specialty. So I want to let you guys know that I've trained specialists and GPs, been doing this for several years, and the principles that I follow are just coming from the best of the best. Research shows that if you are in proximity of very high functioning people by just 25 feet, you start to get a higher level of awareness and growth by just being in proximity, right? I know y'all heard the term that if you have five broke friends, you'll be the sixth. It's all the same. The reason why I was able to go from a 2.46 GPA to being top doctor when it comes to third molar surgery and lecturing at Chicago Midwinter, the NDA, Yankee. I got three other uh, conferences that lined up and also one international for next year. The reason why this is happening is not because I'm smart, not because God said, hey, I'm going to come down and just do whatever. No, I had to, number one, acknowledge that I had to humble myself. I had to get with the smartest people in the room. I had to, I had to, hold on one second. I had to put in the work. I had to humble myself. I had to do a lot of free work. And once I got to that point, I was able to provide this service. And I got to a point now where thermal surgery and surgery is just boring for me. And that's why I like to just teach because I see a lot of you doctors, y'all have greatness inside of you. And the only reason why you're not in the position I'm is because just time and just information. And so I want to share with you that it is possible because I used to push teeth in the sinus. I had a paresthesia. I'm sharing with you my failures. And I want to make sure that you guys have the exposure that you need in order to be successful. Last but not least, the reason why I do this is because I want you all to understand that there are patients who have text me, and this is on public format saying, hey, I want to commit suicide because of a botched surgery. This is no longer like taking out thirds and placing implants and making white teeth whiter and straight teeth straighter. But this is like life and death now. I have individuals that are calling me from different parts of the world saying, hey, can you be an expert witness? This is not a game. And so I have a lot of fun time. But when it comes down to like teaching and surgery, it's super important because this could be your spouse, this could be your child, this could actually be you. And especially being in the profession that we're in and understanding where we are as clinicians, we always want to be able to give the best and the brightest. And I believe that you guys are the best and brightest because I've been an educator and I want to let you guys know that just by default that you're listening to this lecture, you are there. So don't think anything otherwise. With that being stated, I want to just share with you how I went from a 2.46 GPA to being one of the top leaders of third molar surgery as a general dentist, right? I'm not an oral surgeon or anything like that. I'm oral GP, just like most of you guys on here. So here's some of the results of some of the doctors that have been able to train. This is Dr. Troy and Dr. Daniel. Fam said over here, Dr. Williams, Dr. Troy are very cautious and attentive while removing all four of my thirds wisdom teeth, right? Some of y'all are from UT. She went to UT. This is Dr. Daniel. They're getting 5 star. Patient said, I'm very nervous for my wisdom teeth removal, but Dr. Daniel and his team made sure I was very comfortable before, during, and after the procedure. Dr. Daniel talked to me through the whole process, which was super helpful. Everyone was so comforting and kind to me. I'm very happy with my experience. I'm so grateful to be a part of the Smile After Surgery program. These doctors are getting 5 star reviews in the very first attempt. These aren't their patients. These are patients that we just saw brought to them and they're provided doing the same stuff I'm sharing with you guys today. This is Dr. Gregory. He's out in DC. He came and took the course. Patients are giving 5 star reviews. This page, Alicia said, they help pull four of my wisdom teeth with no pain or problems. If you're looking for great dentists, contact them. They are a blessing for taking such good care of me and helping me during my toughest times. I want to let you know, like, your patients will say the same thing about you if you follow the tips and tricks that we just shared with you today. This is Dr. Collins. He's one of the past presidents of the Greater Houston Dental Society here, um, showing you his case. As you can see, if you are young or old, it doesn't matter where you are. Everybody's wanting to figure out a way with the tariffs that are going on, the stock market going crazy. How can they bring in more revenue and become a better doctor? Third molar surgery, like we talked about, is over $3 billion business in 2007. It's 2025 today. If you are a doctor who's about to graduate, this is Dr. Abbasi. He came, learned the same information I'm giving you, and this is the case that he started working on. The first case, the very first case he started working on, number 17. As you can see right here, the teeth are gone. he said to me, I took out the lower ones, doc. Thank you for your instructions. And like I always say, what looks hard is often easy. It's the same exact thing. There was no happy emojis, just hey, it just is what it is. So it doesn't matter if you're old or young, it doesn't matter where you are in your training. If you follow the principles, you're gonna get success and you're gonna get it quickly. This is Dr. Balagoon. Now, this was a crazy case because I asked her, I was like, yo, why the heck are you taking out cases like these? She said, Dr. Williams, all I did is follow the principles. It shut me up. It shut me up. This is Dr. Balagoon. I want to say she was in Indiana. So if you know some of these doctors, you can kind of know, um, pull them aside and say, hey, is this really true? These are all their cases. And I want to let you know if you are struggling with third molar surgery, you don't have to because I showed you doctors who are older, younger, the same skill set, less skill set, and they're doing crazy stuff. None of these cases I would have ever started out with. In this case right here, Dr. Balagoon could have broke the jaw and had a paresthesia, but you could see it right here, 2 thumbs up.
Hey guys, now I know you're super excited to implement these systems and techniques into your practice, but I know it can be a little daunting, and that's why I decided to create a little cheat sheet so you can implement these with ease and predictability. Let me show you what they look like. Here's the cheat sheet offered just for you. All right, so in this cheat sheet, you're going to get a quick reference tool to optimize your surgeries. You're also going to be able to have this webinar to be able to have the flexibility to record, rewind, come back, and reinforce your learning. Also, I'm going to pair you up with one of my team members or even myself as well to have a 60-minute consult to answer your specific questions that are tailored to your patients. And last but not least, I'm going to give you my book called How to Get Any Patient Numb, Third Molar Edition. This copy, what you're going to be able to do is know all the tips and the tricks that you need in order to be successful. And this is exact techniques that I give and I use on a daily basis to where if I have a patient and I can't get them numb, it's the information in this book that's going to allow me to do so. And I'm sharing that with you. Now, typically this information would cost thousands and thousands and thousands of dollars, but we wanted to make the barrier entry so low that even if you did one surgical extraction, you'd be able to pay for all this information. And the benefit behind that is the information that you gain is with you for a lifetime. Not just the information, but also the recording and the webinars. So you have no excuse but to take action. My goal is to make sure that you have the cheat sheet, the recordings, also a 60-minute consultation with either myself or the team, and How to Get Any Patient Numb, Third Molar Edition. Now, like I said, you're getting all this information for less than the cost of one surgical extraction. So there should be no reason why you don't take action. Now, I know that you guys are out there thinking like, man, can I really do it? Well, I want to let you know, we've had so many doctors, like I showed you in the webinar, who had just graduated out of dental school and been practicing for over 20 or 30 years and are having success. Also, this is the same information to where I'm being called to give lectures such as Chicago Midwinter, the Yankee, the NDA, and also some other major conferences that you're going to see me at in the near future. So you might as well take action before this offer runs out. I can't guarantee that we're going to be able to have time to work with everybody, but if you act now and click the link, you're going to be able to secure your spot so you can ask the questions you desire. You're going to be able to get your patients numb. You're going to be able to review the content, and you're also going to have the cheat sheet for your quick reference guide so that when you're going to surgery, you'll be able to implement at a high level. Now, I know you're thinking, well, doc, what if I am a dental student? What about that? Well, we got you covered as well. You're going to be able to get a recording and the cheat sheet, and it's $47. It's almost the cost to go to get Chick-fil-A or get some food. We wanted to ensure that nobody was left out, and we want to ensure that you have the information to be successful. Now, I want to let you know there's no reason for you not to take your skills at next level. My focus is to give you the education. Your job is to trust yourself, invest in yourself at such a low barrier of entry, and take your skills at next level. because the world is changing and they're looking for competent doctors who could treat them. So there you have it, guys. I want to let you know this offer is not going to last long. Once all the slots are gone, they're gone forever. So go ahead right now, invest in yourself. Click on the link for less than a surgical extraction. Get the cheat sheet, get the recording, get the 60-minute consult, and get the book, How to Get Any Patient Numb, where you're going to ask yourself, man, how come I didn't invest in myself sooner? All right, guys, I'm Dr. Jared Williams. I hope you loved the webinar. And if you did, ping me or shoot me an Instagram message at the JW Method or email me at info@jaredwdds.com. All right, guys, remember, you deserve to smile through surgery. Make it a great one.